Let me introduce Dr. Pankaj Kundra, Professor Pankaj Kundra, who hails from Pondicherry, India. Pondicherry is where our previous regional Anaesthesia Asia was held a couple of years ago. He's a senior professor and head of the, mind you, Biomedical Engineering and Engineering Division, Department of Anesthesiology and Critical Care, JIPMA Institute. It's a huge institute in Pondicherry, India. He also is a professor in charge of fellowship program in anesthesiology and critical care, and committee member of the RA Asia, as well as the associate editor of the Indian Journal of Anesthesia. So Prof. Pankaj Kundra will present will talk to us about role of RA in physiotherapy and rehabilitation. The floor is yours, Professor.
Good afternoon, everyone, and it's a delight to see so many people still inside the hall after the late afternoon sessions which we are going through. Well, the topic is something the anesthetists are not very frequently involved, but in our institute, yes, we are called for it because we play a very active role in seeing how the patient's goals are achieved even when they undergo physiotherapy. Now, I'm going to limit my talk only about the physiotherapy which is being used to the maximum extent in the major joints, because rest of the things are not pertaining to us generally. So these are the two major joints where the physiotherapists and the rehabilitation occurs. So I'm going to focus upon them. And the conditions which you normally encounter, pain which has to be relieved so that the patients can undergo good physiotherapy exercises, is one is frozen shoulder, the other is knee arthroplasty. So let's talk about the frozen shoulder first. Now this is nothing but an adhesive capsulitis, and there is always a limitation of movement and pain during movement when a person has a frozen shoulder. There are various causes which have been defined, and of all the causes which are there, it is perhaps more common in men, in females, especially in the post-menopausal stage, and in the age group of about 40 to 70 years. Pain is the most limiting cause because that is what needs to be taken care of if the patients can exercise on daily basis. And physical therapy, if given appropriately, would probably result in good range of motions, and it takes about a year to happen to develop into that. So a good pain relief during the physiotherapy exercises would probably help the patients to overcome this stiffness within a month. What are the treatment options which are available? Most commonly, it is the steroid injections. There are certain joint distensions which are done to increase the stretchability of the tissues. Shoulder manipulations are done so that the tightened tissue is loosened around under anesthesia. Shoulder arthroscopy is generally done to make sure all the adhesions are released. But the most effective of all of them probably is a shoulder block, which will provide painless physical therapy and to some extent mild manipulation of the shoulder joint as well. Now we have already discussed what does the supply of shoulder joint consists of. But please remember that the shoulder joint has a supply both from cervical plexus as well as the brachial plexus. So if you look at the areas which are supplied by the cervical plexus, is basically the transverse cervical rami of C2 to C3, the supraclavicular part, and from the brachial plexus you will have the axillary nerve from C5, and you will have the medial cutaneous nerve of the arm. And then if you look at the dermatomal supply, you will have C3, C4, and then C5 together with T2, T3, and T4. So this is the cutaneous dermatomal supply and the nerve supply of the shoulder. Now, what do we need to focus at? If you have to treat a patient with a frozen shoulder, the main aim would have to be that there should be no option of muscular weakness at all. The sensory innervation or the sensory block should be good, but the muscle strength should be preserved so that the physical therapy can be successful and the muscle tone can actually increase after the physical therapy. So if you look at the joint as such, you will find that the shoulder joint is supplied basically by the suprascapular nerve and the axillary nerve. The capsules, the glenohumeral joint area, both of these areas are supplied by these two nerves. So if we can achieve a block of these two nerves, probably the innervation of the shoulder will be taken care of and the patient can have painless movements of the shoulder joint. So there were different aspects which were discussed, papers which have been presented. But how do we go about giving it? Normally we will ask that the patient stretches the arm and places it onto the opposite side so that the scapular area is stretched out. And you will have to put the transducer there. And this is the spine of the scapula. And you have to bring down the transducer from the medial to the lateral part. So as you come to the lateral part, slowly you will see that you will come to the suprascapular notch. And when you come to the suprascapular notch there will be the artery and the nerve which will be situated. So if you look at if you move your transducer over to the back, over the spine of the scapula from the medial to the lateral aspect, you'll find this is the spine of the scapula, this is the medial side, and this is the caudate side. The upper one the upper part is the trapezius muscle, below that is the supraspinatus. And then we go towards laterally, and you'll find that this is the suprasternal notch, and the spine of the scapula just takes a dip at this point. And within the suprasternal notch, it is covered by a transverse superior ligament. You have the artery here, and you also have the suprascapular nerve here. Now, what we need to remember is that in order to get to the suprascapular nerve, if you go in line to the needle, if you put the needle in line to the transducer, then you will have to pierce through the ligament. And the needle will tear through the ligament. We don't want to do that. So at no point of time we need to damage the ligaments at any point of time. So what's the option? The option probably would be that you go with a needle walk down technique, and that's in the short axis. Now if you put your transducer in this short axis, and this is the area of interest which we want to look at, this is the suprascapular nerve, you'll find that if you put your needle down here, unless the needle tip comes to this point, it will not be visible onto the ultrasound screen. So now we don't have the needle coming here, but as soon as we push the needle forward, that's the point the tip of the needle will appear. But it is far away from the nerve. It is right above. So what we need to do now is to tilt it a little more, about 45 degrees or a little more so that it can go down vertically, and then again pass the needle down so that it touches the area of interest, and you will find that the needle tip has now come onto this point. So this is how the short axis method of going ahead and getting to the nerve is possible. With this method, you will not go through the ligament, you will not tear the ligament, you will not damage the transverse superior ligament there. And to my knowledge, this is a much easier method rather than the needle in line, right? We all are a little more convinced that inline needle is the best method because you can see the entire length of the needle. But to get the entire length of the needle is also a difficult task. In case you can do the short axis, this part is always visible. It's not difficult to visualize it. It's only the technique that you master, that when you see it, how much angulation you have to give so that the needle tip crosses the ultrasound beam, which is about 1 millimeter, and you will always hit the target. So that's the way you could go ahead for the suprascapular block, which is the safest way without damaging the ligament. Now, there are various studies which have been done which prove that the suprascapular nerve is beneficial when used for chronic shoulder pain. This is one of them which was done, and it was used basically in degenerative diseases. And what they did was try to see the disability index together with the range of motion till about 12 weeks. The results were quite interesting, that all the pain scores, the disability scores, and the range of movements only with a suprascapular nerve block using bupivacaine and methylprednisolone as a single injection was extremely useful. So just a single injection would do the trick in these kind of frozen shoulders. And if you look at these scores, which were these scores which were taken as the total index of disability and pain, all of them showed that there was a significant improvement with bupivacaine and methylprednisolone. Now, there was another study which was done with the suprascapular nerve block for frozen shoulders. This was only in about 10 patients. And in these patients, they were all refractory to intra-articular injections of corticosteroids. And what they could do was that with a suprascapular nerve, with prednisolone and lignocaine, even after 1, 4, and 12 weeks, there was quite a lot of improvement in pain scores and the range of motions. So I mean to say is, in frozen shoulders, just a suprascapular nerve block may do the trick. But is it all good, all nice that only a single nerve can be blocked to give you the good results? Actually, you will see that it does. In most of the cases, you'll find that the pain scores have come down significantly after the suprascapular nerve block was given. However, when we see in our institute, we find that if you can combine that with the auxiliary block, a low concentration of bupivacaine, if you combine it with the auxiliary block, the results are extremely encouraging, and within a week's time, the patient's range of motions come back to almost 90%. So how do you go ahead and do this auxiliary nerve block? Now you look at this auxiliary nerve block, the transducer has to be in a vertical axis to the arm. And you keep moving the transducer till you find that the trapezius and the deltoid come into the vision. There will be a pattern of the deltoid which comes here, and this is the trapezius muscle. This is the junction of both the two muscles. And what do you see at this point? You see that the humerus is there. This is the deltoid, and this is the triceps. So this is the triceps fold which you see behind the arm. This is the deltoid, and this is the shaft of the humerus. We go ahead and move the transducer a little more superiorly towards the head end, and then you will find that at that particular point, you will have the artery here, you will have the nerve here. So if you have these two, the posterior circumflex humeral artery and the axillary artery, this nerve can be easily blocked here, and a single injection of this posterior axillary nerve with the suprascapular nerve does a lot of good to patients, and the recovery is quite encouraging. Now let's go to the knee joint and arthroplasty. What are our key concerns? One is that we need motor evoked pain relief within 24 to 48 hours. The patient should have complete relief. Then at about 3 to 4 months, they tend to develop the joint stiffness. And this stiffness has to be taken care of to see that the range of motions are good and the patient's weight bearing is good. When you look at the physiotherapy targets, you'll find that the arc of motion is what determines what is the limitation of the joint. And all these activities, from walking to lifting the object to stair climbing to sitting to shoelace tying, has a different arc of motions. And the different arc of motions which we need to take care of is almost going up to 95 degrees now. Initially in 2002, less than 70 degrees was accepted. But now the demand is more, and we want that the arc of motion should not be less than 90 degrees whenever we want all these activities to happen amongst the patients. So the targets have been revised. The physiotherapists need to achieve, and the patients also need to achieve, this kind of range of motion to almost having less than 95 degrees. So at no point of time they should have less than 95 degrees of range of motion. So what can we do at these particular times? What are the causes of joint stiffness? There can be preoperative causes, there can be intraoperative causes, there can be post-op causes. But are we concerned? What are the points as an anesthetist we can take care of? Probably only the post-operative causes, because we do not have any role in patient selection. It's the surgeon who selects the patients. Even in post-operative part, it's the pain management regime where all of us play a very major role in making sure that the joint stiffness doesn't occur. What do we do? Do we give IV PCA opioids at time, or do we give local blocks? And all we know is that pain at rest and at movement, even when you give these kind of parameters, you know that you need to have local blocks which will give you a better pain relief. So the anti-inflammatory effect of peripheral nerve blocks has been demonstrated after knee surgeries. And if you look at the VAS at rest and VAS of movement, even after third and the fourth month, you'll find that the patients who have received a block have much better pain relief and movement rather than patients who have received IV PCAs. The skin temperature, the skin circumference, if you look at and compare it with the contralateral knee, you'll find the patients which have a block have lesser knee circumference, that is the edema is less, the skin temperature is much less, and therefore the inflammatory actions of the local anesthetics was probably described in this particular study. But what do we do? What kind of blocks do we select? Now this is a recent study in 2016 which was published. They have tried to compare continuous femoral nerve block, a single short femoral nerve block, and a local infiltration analgesia which is given around the knee by the surgeons. What was their primary outcome? They wanted to know what was the pain at day 2 during physiotherapy. The secondary outcome was to see the pain and chronic neuropathic pain even after 4.5 months, 4.5 months. And they did all these tests, time up and go at second postoperative day, range of motions at 4.5 months, the 6-minute walk test, the lower extremity function scale at 6 weeks and 4.5 months. So looking at all these outcomes, it was interesting to see how their study design was. They had all the patients which are covered up by anti-inflammatories, gabapentin and acetaminophen. They were given boluses that was blinded and randomized. All patients received spinal bupivacaine and fentanyl. Intraoperatively, they gave sedation with propofol, titrated to Ramsay scale. It was a placebo kind of a double-blinded controlled trial. Post-operatively, all of them got all this multimodal analgesia and infusions. And what did they get? The finding was finally that on second post-operative day, there was no significant difference in analgesia in either of the groups. Motor block to a blinded physiotherapist also was almost similar. No differences were observed with a single short femoral block or with a continuous femoral block. And long-term outcomes, there were no differences in the group. So what it tells us is that even in a long term, if you can give a single short femoral block, it probably works and the outcome measures are good. So there were no complications which were seen by the femoral block. There was no falls, no infection, no persistent neurological deficit. So the conclusion of the authors was that there are no differences between any of the blocks. The secondary analysis says that the continuous femoral block and the local infiltration are to some extent superior to a single shot during the early time. But in the long term, even if you give a single short femoral block, it seems to work. What about the risk of falls? When we give femoral blocks versus adductor canal blocks, which is being popularized now, are there any risks involved? And in this particular study, they used 2.2% ropivacaine as a continuous infusion. They did the 1080 score, and this 1080 score is done for gait and balance. And if the 1080 score is less than 19, then the risk of fall is high. The secondary outcomes were manual muscle testing, timed up and go test, and ambulation distance. And what were their results? The results was the 1080 score less than 19 was observed with both adductor canal block as well as with femoral nerve block. Though the incidence was less here, but it was almost comparable in both the groups. The manual muscle testing grades was actually more, the muscle strength was more preserved by the adductor canal block. The ambulation distance and the tuck test was similar. So the conclusion was that the adductor canal block results in greater preservation of quadriceps muscle strength, and there's no significant reduction in fall of risk with adductor canal block or with femoral nerve block. But can we accept this when we have a patient who has to go physiotherapy for joint stiffness after 3 months? Probably not. None of these two blocks would meet the criteria to develop muscle tone and to have complete relief from the joint stiffness. So what are the options which we are left to? We probably have to go a little more peripheral. So the options were coming onto the genicular nerves. So genicular nerves are the nerves which are the finer branches of the major nerves which we normally deal with. So neurolysis of these nerves at the supromedial, infromedial, and supralateral area provided significant joint functional improvements. Where are these nerves located? And this is the future for knee joint. Please let me tell you that. Because this is something which will preserve the muscle strength to the maximum. It may also cut down the incidence of joint replacement. It's also used as a treatment option for osteoarthritis management. So what is normally done? These three genicular nerves, the superior medial, the superior lateral, and the inframedial, are the ones which are blocked at the sites of these particular areas. How do we know from where do they originate? If you look at the nerve supply of the knee joint, you'll find that it is coming from common peroneal, the tibial nerve, which is dividing into the superficial peroneal and the deep peroneal, and the saphenous nerve, which is a branch of the femoral nerve. So what are these genicular nerves? From which of these nerves it arises? All we need to know is look at the arterial supply of the knee joint. The arterial supply of the knee joint is almost complementary to the nerve supply. You have the superior lateral genicular artery, infralateral genicular artery, supromedial genicular artery, and inframedial genicular artery. And all the nerves are complementary and side by side to these arterial supply. And the arterial supply gives us the clue to look at during the power Doppler to pick these arterial pulsations and deposit the local anesthetic near to it. We may not be able to see these nerves, but we will always be able to pick up the arterial pulsations. And if we are able to do that, an effective block of the knee joint can be provided without loss of muscle strength. And these are the 3 points which we need to look at to block these kind of nerves. So you have the superior lateral genicular nerve, which is corresponding to the artery, the superior medial genicular nerve, which is corresponding to the medial genicular artery, and the inframedial genicular nerve, which is corresponding to the inframedial genicular artery. So let me show you the ultrasound. Looking at this particular area, the junction between the epicondyle and the shaft, if you place your probe there, you will be able to find these pulsations here. That's the pulsations of the supromedial genicular nerve. We try to put some local there. It's gone around, but we again come back with the needle to come a little below and then deposit the local anesthetic there, and that would help. So this is where we come, and you deposit the local anesthetic here. Around the artery, you will be able to block the nerve. Similarly, for the inframedial genicular nerve, you need to bring the needle close to the arterial pulsations which you have picked up, deposit the local anesthetic just near to the artery, and you will be able to block this inframedial genicular nerve. So all you need to pick up is the arterial pulsations and deposit the local anesthetics near to that. 3 injections done in this way does a lot of good. There is literature which is coming up, but only in form of case reports. We have only preliminary reports which have come up, but it may be a path changer in the future. This is done in about 15 knees, and the VAS scores have shown significant reduction in pain, and actually the range of movements have improved after it has been done. So what they have done is the radiofrequency ablation, the pulsed radiofrequency ablation of a painful arthritis, and the patients had significant pain relief and could undergo physiotherapy in a good way. If I can just take 2 minutes, just to give you an idea about what we want to tell. I'm talking about chest physiotherapy. This is something not related to regional anesthesia, but as a part of physiotherapy, just to tell you the timing of an epidural. Now, this is a patient who had come to us with head trauma and chest trauma in ICU. Last month, she was a daughter-in-law of the Inspector General of Police from one of the big states. Look at the ribs which have been fractured. There's a stove in chest here, and all the ribs from 2nd to 8th ribs are fractured. She was on ventilator, had 9 ventilatory days. We gave only sedation and analgesia till she was on ventilator. 3rd day, when we are trying to put her on non-invasive ventilation, that's the time we started with our epidural. So the epidural didn't start right in the beginning to relieve pain, because the patient was not conscious enough. She was struggling. She had to be sedated. So we just reserved our epidural options till we are ready to extubate the patient. So from the ICU, we took the patient off, gave her epidural, put her on NIV, and actually she was able to cough out and do all the breathing exercises quite effectively. We just had to keep the epidural for 3 days. And within 3 days, her PF ratios improved to almost 400. So that's the amount of, just timing the epidural at the time when the patient needs it most for physiotherapy can also help. So summarize, the major joints require physical therapy. Pain relief is a must to do a better physical therapy. And you must make sure that it is only the sensory block, because we need to build up the tone of the muscle by doing the physical exercises. Frozen shoulder physical therapy helps. Just single shot injections would do the trick. Knee arthroplasty after early mobilization, when you have joint stiffness, probably the genicular nerves with pulsed radiofrequency ablation would be a good choice in future. Thank you very much.
Thank you so much, Professor Kundra. I believe you have a lot more to share with us, but for the interest of time, we need to proceed with the next session. Before we close this session, let me invite Dr. Khoo Eng Lee for a token of appreciation. Thank you for your contribution. And Prof. Kundra, thank you, and I hope you enjoy your stay. Thank you. I pass the mic to our MC.
Thank you, Dr. Afifi.